So thank you to everyone, and in particular, thank you, Governor Shumlin, for your leadership in enabling us all to work together and to advance so quickly. One of the things that we definitely heard at our recent Policy Academy and our New England Governors meeting is that without leadership, nothing goes forward. At least it doesn't go forward very quickly. So greatly appreciate that. Thank you very much, and thank you for being here today. Take questions?
Yeah, thank you, Commissioner. If you have questions, we will all try and answer them collectively.
How many people are on the waiting list in Chittenden County now?
Right now,
come up here and answer that. We'll be very happy with you.
so right now there's 290 people on the waiting list, but that represents both active and inactive individuals. And as I pointed out, we had, if we include both active and inactive, going back to January, we had close to 1,000.
And what's the distinction between active and inactive?
So somebody who's on the active waiting list has been screened and triaged. They've made contact with us, obviously. There are certain individuals that are priority populations in terms of triage. So if somebody is, if a woman is pregnant, or if somebody's an IV user, then we want to triage them immediately. And we have support services that are funded both by ADAP and the Department of Health, our Safe Recovery Program. So we work actively with individuals who are on the waiting list. But individuals who would be inactive would be somebody that we have not had contact with within the last 30 days, or somebody who is not able to actually come in if we were to call them in that week. So because we've had waiting lists, there are some individuals who are calling to try to position themselves on the waiting list, but they're not really actively able to come in at that moment in time.
How long was the inactive list, did you say?
We had somewhere between 900 and 1,000 people back in January. And right now, the total waiting list, active and inactive, is about 290.
Governor Shumlin, this spring when you told us about your concerns over Zohydro, you mentioned that you had sent a letter to Canadian officials urging them, or their version of the FDA, to consider a non-crushable form of oxycodone. Have you heard anything from that? Make any progress there?
You know, so two issues. One is Zohydro being a bad idea being approved by the FDA, which a number of Northeast governors sent a letter to the FDA and to the folks in Washington saying, listen, you know, if you think OxyContin was a problem, Zohydro is OxyContin on steroids. Don't approve this drug. Rescind your approval of this drug, and certainly make it tamper resistant. On the Canadian issue, the issue has been that on OxyContin, they are selling non-tamper resistant OxyContin in Canada. And a number of us have approached Canadian officials. I was with Premier Couillard yesterday, and the subject came up. He's very supportive of this. And we are putting as much pressure as we can on the Canadian government to make sure that any OxyContin or painkillers that they sell are also not crushable and not snortable. And we hope we're making progress, but they haven't made a final decision.
And no reversal about Zohydro either?
There has been no progress that I'm aware of on the Zohydro front. I will say that more and more governors are weighing in, because we really believe that what got us into this mess of heroin addiction was OxyContin that was approved by the FDA, that we passed out with great exuberance, and that was both crushable and snortable. And the notion that you know, FDA's own advisory board would vote 11-2 or 11-3 not to approve it, and then the FDA approves it, and it's not tamper resistant. It just defies logic.
The increase in treatment would suggest that demand would be down for opiates. Is there anything to suggest that supply is falling as well along those same lines?
I'll let the Colonel take that one, but my guess is the answer is no. I think we have to remember that the treatment numbers that Bob just ran over and the rest of us ran over, you know, we've gone from treating 1,700 Vermonters to almost 2,600 very quickly. So let's remember that when the governor goes out and says, we're not going to discriminate against you, we're not going to pass judgment on you, we're not going to lock you up, we want to get you treatment and back as a productive member of society, it opens up the floodgates of those who are out committing crimes, shooting up, and remaining addicted. So that's what's happened, because I believe we as a community, as a state, have said, you know, we're not going to turn our eyes to this anymore. We've got treatment. We want you. People are coming forward. Did I screw that up, Carl?
No, you got it right on.
What is this doing for people in really rural communities that might have trouble accessing services? How are their needs being addressed?
Well, I should let the commissioner take on, but I think it's important to note that we're building out treatment facilities not only in our most urban areas, but in our rural areas. As you know, the Kingdom has services now. We just opened up a really state-of-the-art center in Rutland a few months ago. We're looking very closely, working together with the Bennington community to see if there's some work to do there in terms of the potential for a treatment center. I've personally met with leadership down there, as well as Tom D., the CEO of the hospital. So in areas where, I mean, my goal is to ensure that no Vermonter has to drive, from 30 minutes, 40 minutes to get treatment. It's just, it should be no different than any other disease.
Is that the case right now? Are people having to drive?
There are still instances where people are driving further than we'd like, but we currently, as Governor said, we have in our hub system, we have 7 different locations where people can access treatment all around the state. We're working to look at whether there needs to be any new locations. But also I'm going to ask Tom to come up and say a little bit more about the spokes. We haven't talked so much today about the primary care doctors who are also able to see opiate-dependent patients in their offices. And we have a network of physicians who are working in tandem with the hubs so that once people are stabilized and able to move back to their home community for maintenance care, they could be seen by their primary care physician. So,
yeah, again, that's a pretty key part of the whole system, to actually have flow between intake portals once people have been stabilized, and then where they can go once they have been stabilized. And the more effectively we can enlist the primary care providers throughout the state, the more we can address the travel times that are necessary for ongoing care so that people can get care in their own backyards more and more, and that we can assure the hubs that as people get stabilized, we can move them into community support and make sure that the front doors of the hubs remain wide open so that we can never have waiting lists, ideally.
What is the capacity of the hubs across Vermont? How many people could we treat at once?
That's a good question. Do you happen to know that?
well, I would have to sit here and do math skills in my head, but if when we're up and running, we're pretty close to where we want to be with the 2,500. Several hundred more with the current capacity, and the challenge we're having right now, would you agree, Dr. Simpatico, is getting enough primary care physicians to be open to taking more patients who need continuing care. Some of these folks can be a little bit challenging, but we've been trying to provide training and support so that we can get more people being, flowing out of the hubs and being stabilized in their own communities.
Is that because doctors don't want the lower Medicaid payments?
It's for a lot of reasons. It's really a new patient population, or it's perceived as a new patient population. I think as Barbara says, the more we go out and talk to the different factions of the primary care community, certainly in principle, they generally agree that this type of work should be a staple of primary care provision. It's a ubiquitous problem. It's people from every community in the state. So that a primary care doc taking care of a local population wouldn't be involved in this is really kind of at odds with many people's clinical philosophies. What gets in the way are many issues, one of which is the smoothing relationships between the intake portals of the hubs and the spokes, where people are more stabilized. And if people start to recidivate and need to go back, the primary care pool having confidence that there is the capacity for backup if they need it. So we're making a lot of progress, and there's really different sort of factions of the primary care providers, and I'm confident that we're going to see pretty rapidly an increase in their capacity to see more folks.
Is that a big issue, relapsing from between the hub and spoke and people just going back and forth between the models?
I wouldn't say it's a big issue. I think it's a conceptual issue that, you know, to have a hub and spoke system, that kind of implies that there's a smooth working relationship between those two parts of the system. So as it becomes more mature, as more and more providers are taking part in the system, we're being careful to make sure that everyone is mindful that it is a system and that there is intends to be a smooth working relationship. So we're putting a lot of energy to make sure that that develops as it goes forward.
Commissioner Polito, you've been trying to keep, of course, drugs out of correctional facilities. Now you're bringing them in, obviously well controlled. What will you be doing to ensure that these maintenance drugs will not be diverted somehow once they're inside the Rutland and the Chittenden facilities?
So the issue with contraband in correctional facilities isn't necessarily one of diversion in the first place. If we deliver medications in accordance with our best practice, which is it's delivered by a medical professional in the eyes of a correctional staff, and it's witnessed, and we watch the digestion and so on and so forth, whatever policy we have. We keep that in place. That's one issue. The issue of contraband has to do with the flow in and out. People being lodged, people coming in and out on furlough, visitation over the fences and those sorts of things, so they're kind of separate. The best defense that we have of diversion, though, is good medical protocol, administration by medical staff and witnessed by correctional staff. It's all caught on camera, and we actually see how it's ingested as opposed to being allowed to cheek or whatnot.
I just want to highlight two additional comments on two questions. One was the relapse issue. Listen, whether it's hub and spoke or any other system, we have to remember that this is the most debilitating, awful disease that you can have. And relapsing is a part of recovery for many people. In other words, it's not just a smooth sail back to ensuring that you're not abusing drugs. This is an awful, awful disease to get, and once you have it, you fight it every single day. Second, on the question of primary care physicians treating folks, I think that one of the things that I've learned about this discussion is that we've got to lift the veil on the discrimination, the attitudes that we have about opiate addiction and opiate addicts. And I think that anyone in the treatment community, not just the docs, if they're in a practice that doesn't focus on this particular disease, gets some pressure from the public not to see this disease in their waiting rooms. So when I say that we've got to lift the veil on treatment in our front yards so that we can, and attitudes towards addiction in our front yards, so that we can stop pushing addiction into our backyards, which leads to crime and a lack of quality of life, we've got to all be in this together. And I hope that Vermonters will encourage all providers to offer treatment as they do for so many other diseases.
But Governor, there are dentists that won't take new Medicaid patients. I didn't hear anyone address whether the reimbursements from Medicaid are an issue.
I think, first of all, the question suggests that all people who are addicted are on Medicaid. And I just want to make very clear that this disease affects all income levels. It affects very rich people, it affects middle-class people, and it affects people without enough resources. So just the premise of the question makes me a little uncomfortable, because we got to remember that this is an everybody disease, just like cancer, just like heart attacks.
Do you guys have any sense of what portion of the new people being treated are Medicaid beneficiaries?
We do. I can get that to you. Off the top of my head, I would have to, but I would want to also highlight that the Green Mountain Care Board has been incredibly helpful in getting the other insurers to also match the bundled payment that we're using for our hubs, and that has been incredibly important for people who have private insurance. So our goal is to make sure that everybody has access to care, whatever type of insurance they have, and to have it be equitable across the state.
Governor, this Saturday,
Rob wanted to take a shot at it, or do you not?
Oh, I'm good.
Good,
Oh,
okay.
good.
this Saturday, the DEA is holding one of its drug take-back days. I wonder if you're urging Vermonters to participate?
Absolutely. I mean, anything that we can do to partner with the feds to make progress on this front. We're all in this together. And I think, as has been mentioned here, you know, the fact that this is now becoming a national conversation is going to help us. And partnering with the feds is a big part of what we have to do.
Where can Vermonters that have family members who might be struggling with addiction go to get Narcan?
They can go. There are 5 locations, and I'm going to refer you to our website, the Health Department website. Howard Center is one of the locations, but there are 4 others, and healthvermont.gov, put Narcan in the search, and they'll come up.
Mr. Sands, how many people have taken advantage of the rapid intervention program thus far this year?
I don't have a specific number on that. Certainly the Chittenden program has been up and running for a number of years. Addison started after that. Lamoille and Rutland and Wyndham is about to come online.
Are we talking dozens, hundreds?
If we exclude Chittenden County, which has had hundreds, I would say dozens to date in those other counties, and certainly those numbers will increase over time.
You've had this focus on opiates, and then this last weekend there was this potential of a little meth lab in someone's house. Is that kind of concurrent worry that people will go back to meth or switch to meth? Or?
You know, it's all a worry, and we've got to be vigilant about addiction. And I think the good news about the approach that Vermont is taking, a comprehensive, seamless approach to addiction, is that we'll get better results going forward than we were getting before we had this conversation in Vermont. So, but the answer is yes, and as we know, there's trends. I mean, just 10 years ago, the biggest challenge, I would argue, that law enforcement would have told you, was pills. Pills being sold on the streets, FDA-approved pills. And when they became tamper-resistant and the price differential, now it's pure heroin coming out of South America. So these trends always change. And I think the fact that we have developed a seamless addiction, or trying to develop a seamless addiction system, is going to serve us well going forward with all abuse.
Thank you for providing the tax information that you did provide. You didn't make available your tax year 2012 income. Why not?
I think I addressed that in 2012 when I ran for re-election.
Ran for re-election and did tax years 2010 and 2011. We were still in the midst of tax year 2012 then. This has been your first.
I've always in practice with all the governors that I've ever known that have divulged their income, which is frankly a pretty new thing in Vermont. Governor Snelling never did it. I don't think Howard Dean did it until he ran for president. Governor Douglas and I have, but I've always provided the tax return for the year that I'm running.
So will you provide it for, but you were governor in 2012, obviously.
I was not a candidate for governor, but I was a governor. Yes.
Right. So why not provide, if you think there's merit in the case for providing it in tax year 2013, why not make it available for 2012?
I've just done what I've always done, which is in election years I provide my tax return to Vermonters. And I also, this year, provided a list of my net worth because I hadn't updated that since 2010. I think it's, worth asking the question, am I the only governor, am I the only candidate for governor who's divulged their income tax return or their net worth? I think the answer is yes,
But why, what's your rationale behind not providing that information for tax year 2012?
As is in keeping with past practices, I've always divulged the income for the year that I'm running.
Do you think there's a legitimate public interest in having that information? The stuff that you provided?
What I focus on every day is doing my job as governor, creating jobs, lifting economic opportunity, trying to deal with real crises like heroin and drug addiction. I have yet to have a Vermonter come up to me and say, hey, could you give me your 2011 tax return? I just don't think it's on Vermonters' minds. So, as you know, I'm going above and beyond the law. The law requires no disclosure to give Vermonters my tax return in a year that I run. This year I gave you a list of my assets. That's more than the other candidates for governor have given. They've given you nothing. So I think we're on the right track.
Governor, if you're reelected, do you intend to help the state of Vermont divest in fossil fuels from pension funds?
Well, you know, I was down at had the privilege of being down at the climate a couple of panels, Climate Change Week in New York yesterday. And there's got to be broad-based consensus, I hope, among anyone who was there, and I wish more people that weren't, that we're not moving fast enough.
Divesting,
the worst case scenario for climate change is that you'd see a 2-degree increase in temperature. Now most experts are saying we're looking at a 4-degree increase. So my feeling is that we've got to look at every option that will help move this ball forward. Now, in terms of the divestment issue, I agree with the Treasurer that having a seat at the table and undertaking our fiduciary responsibility to taxpayers of Vermont is a good opportunity to express Vermont's strong feelings about getting off our addiction to oil. I've also said that going forward, I'm willing to look at any suggestions that we feel will help us move the ball.
Somebody was quoted in a news report saying that you had articulated support for divestment. Is that not the case?
Well, I think I've said what I've always said, which is we have a fiduciary responsibility to Vermonters to manage their money and get the best return that we can. Having a seat at the table is a good option for us. But I am willing to look at anything that works, and like anybody, we're seeing this issue evolve. Look, yesterday the Rockefeller Fund announced, the folks who made their money in oil announced that they'll be divesting the Rockefeller Fund from oil stocks. So my message is really no different than it has been. I'm willing to look at any tools that will work. I think Vermont is right that having a seat at the table is smart. Going forward, I'm constantly willing to discuss and look at other things that we can do to move the ball.
One more thing on financial stuff. You listed your income, but not all the sources of that income. Why not disclose that as well?
Well, I think if you read the tax return, you'll see the source of income just like any other American.
Well, but in your Schedule E we would, which is where you would list the $349,000 that derive from S-corps, real estate, royalties, any of that stuff. But it's not apparent on the W-2.
I divulged what I've always divulged, which is my tax return, first whatever it is, pages of it, and that's what I'm going to give you.
Governor, how can Vermonters take you seriously on climate change when you've got 7 personal vehicles and 2 state police vehicles that get 13 miles per gallon?
7 personal vehicles? First of all, I can assure you I don't have 7 personal vehicles.
There were 7 listed on your tax return.
Well, you're counting a boat, a tractor, and some other farm equipment. If that's a vehicle, I ask you to drive it down 89 and see how fast you get there. But having said that, listen, I do own my daughter's vehicles. So we're talking about more than one individual. They have older vehicles. One they bought from their grandmother, which is in my name. Another one they bought from a close friend. So both of my daughters have vehicles. I have 3 trucks. One is in storage. It's a 1952 flathead 6 Dodge that I bought for $400. My first vehicle when I was 15 years old. It's still going strong, but sitting in the barn. Another is a dump truck I use on the farm that probably gets driven 0 miles a year now that I'm not at the farm. And a third is a Dodge truck that I have in my garage just in case I need it. So I doubt that my vehicle ownership will be a surprise to anyone that has adolescent daughters.
And the 13.1 miles per gallon that your 2 Suburbans get in the Vermont State Police fleet?
I don't own them.
No, but you ride them, though.
I can assure you that my transportation, how I get around and who protects me is a decision made very ably by the Vermont State Police, and I leave those decisions to them. They decide how to move me, when to protect me, and how to get me around. I don't make those decisions.
So are you going to ask the Vermont State Police to consider more fuel-efficient choices?
I'm going to ask the Vermont State Police to continue to do exactly what they've done for me and past governors, which is get me where I need to go in the vehicles that they determine are best to move me around.
Thank you.
Thanks a lot.